our speaker, moderator, and everyone present right now. We pray for your guidance as we unlock knowledge together. We ask that you show us how to conduct our work clearly and with a spirit of joy and enthusiasm. Protect us from the illness of apathy and hopelessness. Instead, keep the fire and love in our hearts as we work together with our colleagues. We ask that you challenge us to reach higher and further to be the best we can be for others. Amen.
Hi, everyone. Happy Friday. I'd like to welcome everyone joining us on Zoom and those watching the Facebook and the UP Manila live streams. Before we proceed, please allow me to introduce myself. My name is Awi Kurameng. I'm a specialist medical communicator, and I currently serve as Regional Medical Director of the MIMS Group, joining you from Hong Kong. Last but certainly not least, I am a proud member of the UP College of Medicine, class of 1998, this year's Silver Jubilarians, and I'm very privileged to be moderating today's webinar. So let's dive right in. I am delighted to introduce our esteemed guest speaker, Dr. Anne-Christine Quero. Dr. Quero is an affiliate physician and junior faculty in the Division of Hematology of the Department of Medicine, the Philippine General Hospital, and a hematology consultant at the Department of Internal Medicine of the San Juan de Dios Hospital. Dr. Quero is a proud member of the UP College of Medicine class of 2013. Today, Dr. Quero will walk us through what we need to know about hematologic cancers, the general management approach to these cancers, and the healthcare financing infrastructure in our country that allows us to support the treatment of patients with these very disabling conditions. Dr. Quero, thank you so much for taking time out to join us today, and the floor is yours.
So good afternoon, everyone, and thank you, Doc Awi, for that kind introduction. So we will now be starting with our webinar for today. So I was tasked to discuss about hematologic malignancies and health financing in cancer care in our country. So I have no disclosures, but I do have a disclaimer, which is I am not an expert in the UHC and NICA, and most of what I will be talking about today is an echo of what we've discussed in our society's convention, which was held last September. So my objectives for this afternoon are to provide an overview of the hematologic malignancies and their impact on public health in the Philippines, to discuss the current landscape of cancer care and treatment options for these hematologic malignancies, and to examine the role of health financing in hematologic malignancies in the Philippines. So hematologic malignancies, they are cancers that originate in the blood-forming tissues of the body, including the bone marrow and the lymphatic system. So this results from uncontrolled growth of abnormal cells, and they overtake the development of normal blood cells, which are your red blood cells, the white blood cells, and the platelet. And because of this, they impact the normal production and function of these blood cells, and the signs and symptoms are related to the compromise of the hematologic system, which I will be discussing further later on. So there are three main types of hematologic malignancies. So we have the leukemias, the lymphomas, and multiple myeloma. So this table is from the Global Cancer Observatory 2020 report, or the GloboCan, and it says here that new cases worldwide, we have non-Hodgkin lymphoma as the 13th, and then we have leukemia at 15th, myeloma on the 23rd, and Hodgkin lymphoma as the 28th. New cases worldwide of cancers. And then also in the GloboCan report for 2020 in our country here in the Philippines, leukemia is the 9th in terms of new cases, non-Hodgkin lymphoma 12th, myeloma 22nd, and Hodgkin lymphoma at the 24th. In terms of mortality, leukemia is actually the 5th, and then non-Hodgkin lymphoma still the 12th, myeloma the 22nd, and Hodgkin lymphoma 27th. So taking all of these into consideration, cancer remains the second leading cause of mortality among Filipinos. So the next few slides, I will be presenting data from the National Cancer Institute NIH SEER program, which data are mostly from the United States. So unfortunately, we don't really have these data here in the Philippines. So leukemias are cancers that are characterized by abnormal production of the white blood cells. So there are four main types, and they differ in terms of what lineage is affected and the aggressiveness of the disease. So the acute ones are more aggressive compared to the chronic ones. AML or acute myeloid leukemia involves the myeloid lineage and worsens quickly when not treated. So in the US, it compromises 1% of all new cancer cases. And unfortunately, the 5-year relative survival is relatively poor at 31.7%. In the Philippines, this is actually lower at around 5.2%. Next off, we have the acute lymphoblastic leukemia or ALL, which compromises 0.3% of all new cancer cases. Again, in the US, it involves the lymphocytic lineage and is actually more common in children. Fortunately, children or pediatric patients with ALL also have better prognosis with ALL, but ALL may also affect adult patients. Similarly to AML, its prognosis is worse if the treatment is not initiated early. Next, we have the chronic leukemia. So as I mentioned, they have a more protracted course compared to the acute leukemias. And CML is characterized by the presence of the Philadelphia chromosome. And this is due to the translocation in chromosomes 9 and 22. CML has three phases, which is the chronic, accelerated, and blastic phases. And patients in chronic phase typically have good prognosis when TKI or tyrosine kinase is initiated. However, the blastic phase has poor prognosis and is treated similarly to the acute leukemias. So in the US, again, 0.5% of all new cancer cases is CML. And as you can see, as I mentioned, it has a better 5-year relative survival compared to the acute leukemias. And lastly, for the leukemias, we have CLL. Chronic lymphocytic leukemia is more of a disease of the adults or the elderlies. It rarely affects children. It may also have an indolent course, and patients who are low risk or are asymptomatic with stable blood counts on the CBC may actually just be observed or what we call watchful waiting. So it comprises 1% of all new cancer cases in the US, and its 5-year relative survival is around 88%. After the leukemias, we have the lymphomas. So lymphomas involve the lymphatic system. There are two main types, Hodgkin and non-Hodgkin lymphomas, and management of these two kinds of lymphomas are different. So lymphomas usually presents with painless enlargement of lymph nodes. Hodgkin lymphoma actually has a good 5-year relative survival at 88.9%. Again, this is US data. And we have non-Hodgkin lymphoma compared to Hodgkin lymphoma. Non-Hodgkin lymphomas are relatively more aggressive, and there are the two most common types of non-Hodgkin lymphoma are diffuse large B-cell lymphoma or DLBCL. These are more aggressive. And then we have the follicular lymphomas, which have a more indolent course. So the 5-year survival is again good at around 74.3%. And then lastly, of this very brief overview of the hematologic malignancies, we have multiple myeloma, which is cancer of the plasma cells. So the plasma cells are responsible for the production of antibodies. And this kind of cancer may affect the kidneys, causing renal failure, and they may also affect the bones. causing lytic lesions, and therefore we commonly see the what we call the crab in patients with multiple myeloma. So C is for hypercalcemia, R is for renal failure, A is for anemia, and B is for the bony lesions that we see in this kind of cancer. 5-year relative survival is around 59.8%. So, hematologic malignancies are actually treatable. But of course, early diagnosis will help us to be able to initiate early treatment, and this will in turn translate into better outcomes for our patients. So, every 4-week delay to cancer treatment increases risk of death by around 10%. So, when do we start suspecting the possibility of a blood cancer in order to be able to make the diagnosis early? So, we have the signs and symptoms of hematologic malignancies. They are actually very non-specific. So, it requires a bit of a high index of suspicion. So, we have low platelet count, which might cause bleeding, petechiae in some patients, bruises, and purpura. In females, this may also present as prolonged or heavy menses. And then we also have low hemoglobin. So this will present as pallor, shortness of breath, tachycardia, generalized weakness, and easy fatigability. And in patients with very severe anemia, there may also be signs of cardiovascular compromise. And then low white blood cell counts may cause frequent infections. And then patients with hematologic malignancies may also present with enlarged lymph nodes, especially in lymphomas. And then the liver and or the spleen may also be enlarged. And then, as I previously mentioned in myeloma, bone pains may be common. And then patients with hematologic malignancies may also have what we call the B symptoms, which are fever, weight loss, and night sweats. So once we start suspecting that a patient may have hematologic malignancies, how do we diagnose them? So what we usually see is that in the complete blood count or in the CBC, which supposedly should include a differential count and the platelet count, patients would have unusually high WBC or white blood cell or low blood cell counts that are commonly severe and persistent, and there may be more than one lineage involved. So sometimes if it's just anemia, then maybe we won't be suspecting cancer agad. But if it's like low platelet along with low hemoglobin and then an elevated white blood cell or a high white blood cell, then we might start thinking that maybe this is a hematologic malignancy that will warrant further treatment, further workup or management by a hematologist. So on the right side here of the screen are the normal complete blood count results for adults. So we focus on the hemoglobin. So for males, it's around 13.5 to 17.5 grams per deciliter, and in females, 12 to 15.5 grams per deciliter. White blood cell count around 3.5 to 10.5 billion cells per liter, and the platelet count around 150 to 450 billion per liter. And then another thing that can aid us would be the peripheral blood smear, which would help us to visualize if there are any immature white blood cells specifically, and also other cells such as plasma cells in the peripheral blood. And then for more specialized testing, we order for the PET, CT scan, and the MRI. And then other more specialized tests, again, which the hematologists can help you with, is the biopsy, so the bone marrow aspiration and biopsy, or for lymphomas, lymph node biopsy, which ideally should be an excision biopsy and not a fine needle aspiration biopsy. And then from this tissue samples, we can do immunohistochemistry staining. And then for more definitive workup, we have the flow cytometry, karyotyping and cytogenetics, the FISH or the fluorescent in situ hybridization, and the NGS or the next generation sequencing. And then for the management of hematologic malignancies, once we've established them, so we have the supportive management side, which includes blood transfusion, administration of antibiotics, and for patients with multiple myeloma, we can give them bisphosphonates. And then more definitive would be surgery, chemotherapy, targeted therapy, radiotherapy, stem cell transplant, and immunotherapy with immunomodulating agents or through CAR T cell therapy. So for the stem cell transplant, we actually have uh, hospitals who are able to do stem cell transplant here in the country. Although, as we were discussing earlier, they are here, all of them here are here in Manila. So we have NKTI, St. Luke's, BGC, and Quezon City, Makati Med, and Medical City doing stem cell transplant, both autologous and allogeneic. Asian Hospital and hopefully PGH soon would be able to establish their transplant units also. In Cebu, we have a transplant hub, sorry, but what they do is mostly pre and post transplant care. They are not able to do the actual transplant yet. So while most of these diagnostic tests and management are available in the Philippines, accessibility and affordability remain to be a problem. So accessibility wise, there is scarcity and maldistribution of the health facilities in many parts of the country. And as a consequence of this fragmented service delivery in the country, patients tend to zigzag from provider to resolve an illness, and this results in low quality of care, patient dissatisfaction, and the rapid depletion of the patient's social health insurance or the PhilHealth benefits, which in turn drives higher out-of-pocket payment. So we do not have data on how much expenditure we have for hematologic malignancies, but total health expenditure in the country has grown over the years. So as we see with the red line here, THE or the total health expenditure from 2005 to 2018. So it comes from four main sources, which is national and local governments, and then social health insurance through PhilHealth, out-of-pocket spending, and private spending, which includes private health insurance and donor funding. So out-of-pocket is still around 54%. Here with the yellow line or the yellow bar in 2018, although this has decreased a bit to around 41.5% in 2022, which is actually still a lot. So the WHO has released this framework for action on how to strengthen health systems to improve health outcomes. It defined the health system building blocks, and financing was identified as one of the critical components of the health system, which is what we will be focusing on in the next slides. So we go now to health financing. So health financing is the function of a health system concerned with the mobilization, accumulation, and allocation of money to cover the health needs of the people individually and collectively in the health system. And the purpose of it is to make funding available as well as to set the right financial incentives to providers to ensure that all individuals have access to effective public health and personal health care. So these difficulties are more likely to occur with a disease such as cancer. And that is because cancer is often detected late. So even the most effective treatment will not affect a long-term cure. And then a substantial portion of what is spent by the patients by low quality or inappropriate care that is ineffective. And then, of course, care may be coupled with prohibitive transportation costs and investments of time that include long waits to access care. So, especially with cancer, wherein the chemotherapy or the treatments might be for several cycles. So repeated travel and the month-long treatments will really deplete our patients. So this is why health financing is very important in cancer care. So what do we currently have in our country? So the Universal Healthcare Law and its IRR, as published 4 years ago, so that is in 2019, right before the COVID-19 pandemic. So RA 11223 envisions a progressive realization of universal healthcare through a systemic approach and clear role delineation of stakeholders. So this would result, hopefully, in a greater efficiency in our healthcare system. And at the same time, it ensures equitable access to quality and affordable healthcare and protection against financial risk. So we aim to have better equity across different vulnerable sectors. And then we also have the NICA, or the National Integrated Cancer Control Act, or RA 11215. So this was actually signed into law earlier than UHC. So NICA and UHC were obviously both hampered by the COVID-19 pandemic, but the implementation of the NICA aims to make cancer prevention, screening, diagnosis, treatment, and care, including palliative and hospice care, more equitable, affordable, and accessible for all. So, this is a slide on the oncology fund flow based on the UHC and NICA laws. So, the nice thing about this, as I mentioned, is that it actually covers all the hurdles of cancer care from prevention up until the survivorship or hospice care. So, the funds come from PhilHealth cancer packages, cancer medical access programs, chemotherapy and funding for medications and drugs, chemotherapy, immunotherapy, radiotherapy, etc. So at this point, I would also like to point out that the WHO identified cancer prevention and management as one of the best investments to achieve the UN Sustainable Development Goal number 3.4, and that is to reduce premature mortality from non-communicable diseases by 30% by 2030. And thus, funding for cancer interventions is a priority of our country in order to attain this goal. So we have all the key stakeholders here, which is both from public and the private sector. So under NICA, the CAF, or Cancer Assistance Fund, and the CSP MAP were established. And then other forms of financing support would be from PhilHealth, from the Malasakit program, through DSWD, PCSO, and other HMOs. And then we have also extended PW privileges of cancer patients and PW privileges to cancer patients and survivors, as stated in RA 11215. So we will be discussing CSP MAP and CAF further. So CSP MAP and CAF include priority cancers, and these priority cancers are those with the highest mortality and incidence based on the latest statistics from the population-based cancer registry. So number 5 here are adult blood cancers, and the CSP MAP, Cancer and Supportive Palliative Medicines Access Programs, provides medicine for cancer treatment and palliative care, while the CAF, or Cancer Assistance Fund, provides funding for diagnostics, therapeutic procedures, and cancer medicines that are not covered or are not available in the CSP MAP. So CSP MAP is also known as Ayuda sa Cancer, or AYUSCA, and under the IRR of NICA, it provides free access to medicines that are not yet covered by PhilHealth. So it is a social protection initiative that caters to the indigent and financially incapacitated populations, providing them equitable access to the entire cancer care continuum to achieve better health outcomes and to protect them against financial catastrophe. So, free medicines are available for eligible cancer patients, and the requirements would include a valid clinical or medical abstract from the patient's hematologist or oncologist, and also a valid prescription or treatment protocol. So we have here a list of the portfolio of medicines under CSP map. So this only includes medications approved by the FDA and those medications that are included in the national formulary. So this list should, under the IRR, should be regularly updated in collaboration with cancer technical working groups, and of course, the update should be based on latest available guidelines. So we actually have here medications being used for the treatment of hematologic malignancies such as cytarabine and doxorubicin. And then even for the chronic leukemias, we have here imatinib. So CSP map is actually very helpful for our patients. So, how is the process flow? So, the patient seeks or is referred for treatment under CSP map, and then the patient navigator will determine their qualification. And once they are available, they are enrolled to CSP map and are given the free medicines that are available. And they are also recorded in the registry. But if they are not available, as I mentioned, there are still other funding for these patients, such as through Malasakit Center or through the Cancer Assistance Fund. So this is again included in the IRR of NICA, and this fund is to support the cancer medicine and treatment assistance program of our patients. So this is for both outpatient and inpatient services and medicines. However, of course, professional fees, hospital supplies, and hospital room and board are excluded from the coverage of the CAF. And the requirements are the same. So we have the abstract and the prescription or request. And for outpatient services, even a medical certificate would suffice. There is a cumulative ceiling of 150,000 pesos annually for the CAF. And this ensures the equity of access to the CAF. So these are some of the service coverage under CAF. So it includes biopsies, immunohistochemical stainings, CT scans, flow cytometry, as I mentioned, even the CBC and the peripheral smears are included in CAF. And then they have here this other tests, laboratory or workups necessary to complete the cancer treatment and management for as long as you're able to provide the patient a protocol for these tests. And then therapeutic procedures, so chemotherapy and other chemo-related services, radiotherapy, and then also support to blood transfusion is available under CAF. And then medications, again, that are not covered or not available in the CSP map can be availed or can be given to the patients through CAF. So similarly here, we have the process flow of how to avail the CAF. So whether inpatient or outpatient, the patient will go to the social service department for assessment of eligibility. And once they are found to be eligible, they are given funding for their cancer services. And if not, they are still referred to other hospital funding or other funding support as necessary. So for the patients to be able to avail the CSP map and the CAF, they have to go to the access sites for this. So under the IRR, we have 31 access sites available throughout the country. So as of September 2023, this list has already been updated. So there are now 35. So in Mindanao, we have the addition of Amay Pakpak Medical Center, and for Luzon, Lung Center, Region 2 Medical Center, and Tondo Medical Center were also included to the list. So we now have 23 in Luzon, 5 in Visayas, and 7 in Mindanao. So after the CSP map and the CAF, another source of funding for our cancer patients would be the PhilHealth Z benefit package. So they listed here are the are like how much they can avail through PhilHealth, and a QALL here is for standard risk at around 500,000 pesos. So that's the funding allocated. Actually, adult hematologic malignancies are not yet included in the Z packages, but we are hopefully working on that already. So RA 11463, or also known as the Malasakit Center Act, so this ensures that patients experience compassion and empathy, or malasakit, as well as receiving the respect and dignity and the availment of health services. And lastly, providing also medical and financial assistance through a one-stop shop, that is the Malasakit Center. So malasakit centers are in all DOH hospitals and also in PGH. And each malasakit center shall consist of duly designated representatives from DOH, DSWD, PCSO, and PhilHealth. So the malasakit center shall help patients to facilitate access to the following medical and financial assistance, which includes the DOH, DSWD, PCSO, and even from government agencies, LGUs, NGOs, and other private institutions and individuals. And then we also have funding assistance from PCSO and the SWD. So we have the malasakit centers, but patients can still go directly to these institutions to ask for financial assistance. So confinement assistance, chemotherapy assistance are included here. And for the DSWD, they actually also have transportation for the patients, transportation allowance for the patients. So as I mentioned, the rights and privileges of the PWD are also extended to our cancer patients. And by cancer patients, we mean persons living with cancer and cancer survivors. Um, and this ensures that their social welfare and benefits provided under RA 7277 are granted to them. And further, the DOLE shall adopt programs which promote work and employment opportunities for able persons with cancer and cancer survivors. And lastly, apart from those that are given by the government, we also have financial assistance from the private sectors. So they are still an important stakeholder in the health financing of our cancer patients. So we have outright donations from private institutions and individuals. Some foundations would also give financial assistance for diagnostic tests and medications. Some would even give patients transportation allowance, also scholarship for like the children of cancer patients. So these are available these are available through some foundations, and then also from the different actually pharma companies. There are patient access programs which are able to provide discounted price or bundle deals for diagnostic tests and medications of our patients. So for example, in cancer treatment, and we need 5 vials of a certain medication, they are some patient access programs would be able to provide like a 3+2 bundle. So there are, as I presented, various ways to help our cancer patients to be able to complete, or to be able to diagnose and treat their illness. So, we're already winding up actually. So, cancer is not a death sentence anymore. There are a lot of, we actually have here in our country the diagnostic tests needed to diagnose these cancers. And of course, even the treatment for these cancers and the assistance needed to be able to avail these treatment is already available. So, in summary, there are various hematologic malignancies, and early recognition or diagnosis and treatment will help to lead to better outcomes for our patients. So, cancer care may again be financially catastrophic, but hopefully we have health financing. And health financing is important to mobilize, accumulate, and allocate money to ensure that healthcare is made equitable, affordable, and accessible to all. So, a lot has already been done by the government and other key stakeholders to support persons living with cancer, but there are still so much to be done. So, again, cancer is not a death sentence anymore. So, let us assist our patients in overcoming healthcare system barriers. So I would like to acknowledge Dr. Rene Mayla Agodera Balang for the references that I used for this discussion. So thank you everyone for your kind attention, and I'm happy to answer your questions through the Q&A. And for other questions, you may also email me. Thank you.
Dr. Kiara, thank you so much, no, for that very compelling presentation. I learned so much personally, and I have so many questions, no, and I'm fairly certain that our participants also have many questions. So as we begin our open forum, we'd like to thank our sponsor Takeda for helping make this webinar possible. Okay, Doctora, let's
Yes,
continue
Doc
our
Awi.
conversation from before the webinar because we
Yes,
we had a pretty extensive discussion
we
already
started
before
already.
we started already, guys. Yeah, I just wanted to maybe start by asking about. I was just very curious about your data slide in the very beginning, di ba?
Mhm.
Tapos you parang listed all of the common cancers and you focus on all the common malignancies. Tapos in the data nakalagay doon leukemias, no? Parang was it number 5 or 6? So
Fifth.
which leukemias are those? Like, is that ano ba? Do we have specific data on that? Which one is the most common? The AML ba is the most common?
So honestly, there is no breakdown available. They are just all lumped up together, the acute
Mm-mm.
leukemias and the chronic leukemias. But acute lymphoblastic leukemia are quite common since
Yeah.
they are diagnosed in both pediatric and elderly population.
Acute lymphoblastic. Okay,
Mm-hmm.
okay. Understood, understood. And then also, I was very curious about you mentioned dun sa symptoms, and
Mm-hmm.
I'm asking this particularly because I have an important question. Na parang I feel our primary care doctors and practitioners who are the majority of our participants will really need to take note of. You mentioned B symptoms.
Mm-hmm.
So just very quickly, Doctor, if you can review the pathology and the physiology for us. What are B symptoms? Why do they happen? And why do you have to pay particular attention to them when you're thinking of a hematologic malignancy?
Okay, so B symptoms are more common among lymphomas, and
Lymphomas.
B symptoms are actually inflammatory symptoms, and they are associated with elevated plasma inflammatory markers. So we have the fever, the night sweats, and the weight loss. And the presence of these B symptoms, which translates into elevated inflammatory markers, actually predict worse treatment response and survival for our patients with hematologic malignancies and the lymphomas in particular. So they are included in the um, staging of our patients, and it's also just like very important to discuss this with the patient. So setting the expectations and informing them of their prognosis and the response to treatment.
Thanks for highlighting that, Doctora, no? So I wish everyone po paid attention to that slide, no? When Doctora summarized all of the potential signs and symptoms, no? Of a hematologic malignancy. So Dr. Kira, kunyari nga, you're faced with this patient, you have that
Mhm.
cluster of symptoms. So as people in primary care, di ba? GP, a family doctor, those of us in primary care. So what should we do na kagad? Refer na kagad to a hematologist. Is that the course of action na talaga?
So, as I mentioned, the symptoms are very non-specific. The signs and symptoms are very non-specific, so they can actually happen to anyone, and they can actually be present in illnesses that are not actually malignancies yet.
Mm-mm,
So, what I
mm-mm.
would suggest is to do kahit just the preliminary, which is the
The
CBC and like
CBC,
the peripheral blood
and the
smear,
peripheral smear.
and if there are really abnormalities that are very severe and also persistent, or as I mentioned, if more than one cell line is affected and you're really suspecting hematologic malignancies, then it's really best to refer to your friendly hematologist so that we might be able to initiate already the necessary workup. And yun nga, because early diagnosis would also translate into early treatment and better outcomes for the patient.
Thanks for highlighting that, Dr. Arna. So I hope everybody caught that one. So obviously, first thing to do really, once you suspect hematologic malignancy, CBC and peripheral smear as kind of like your baseline thing to order, no? Para at
Mhm.
least you'll be able to at least document some sort of abnormality there. And then next step, refer na to your friendly neighborhood hematologist. But to that point, Doctora, and I remember, and I wanted to bring this up, we were talking
Yeah.
about this earlier. Yun nga po, di ba? So obviously this whole healthcare financing is a healthcare system issue. The number of hematologists, di ba? Not to put the hardworking hematologists on the spot, but Doctora, could you maybe give people a sense of how many there are in your specialty? Di ba? Adult hematology po kayo,
Yes.
right?
Yes.
Or can you kind of like, so obviously, how many are you in Luzon, in Visayas, in Mindanao? Oo.
So actually there are few of us still. So we're welcome to have more trainees, but there are actually around just 120 adult hematologists all over the country, and majority of which are in Luzon, but there are around 20 both in 20 in
Mm.
Visayas area, mostly in
Okay.
Cebu, and then
Yes, yes.
also 20 in Mindanao. So
Okay,
still
okay.
few, but
Oo.
hopefully we're able to get more doctors interested in hematology.
So the majority po kayo are in Luzon, no? Oo. And then
Mm-hmm.
but still at least we all know now, and you've explained to us at least 20, no? At least in the Visayas, no?
Mm-hmm.
Around Cebu, I guess, no? And then
Mm-hmm.
in Mindanao naman, there are at least 20 of your colleagues that
20s
we can
also.
refer to, no? Oo.
Yes.
Opo. No, that's fantastic. And yun nga po, a lot of our participants are asking, do you have enough hematologists in the country? I guess the short answer to that is not enough, no? But at least you have at least, this group of hematologists in each of the areas naman. And are they
Yes.
clustered, Doctora, in, syempre, the big urban centers, no? Like in Manila,
Yeah. Mm-hmm.
most of you are in, like, Asian, in Makati Med, in St.
A
Luke.
lot are still in the Metro Manila area, but we do
Mm-mm.
have hematologists from like Ilocos to Bicol
Mm-mm. Mm-mm.
area
So
in
at least naman
Luzon.
in each
Yeah.
region, may mare-referan naman na
Meron naman.
hematologist.
Yes,
Okay,
it's
okay,
just
okay.
really I guess the transportation also that's hard for our patients. Kasi even if there is a hematologist like in Region 2, of course the provinces there are still far apart from each other.
Yeah, yeah. Opo, opo. Okay, okay, that's great. I just wanted to pick up on a point that you introduced a while ago. The issue then also is, kunyari, you need definitive treatment na, no? Tapos kailangan
Mm-hmm.
mo ng stem cell transplant.
Yes.
Unfortunately, if you can elaborate on that a little bit, sabi mo there's only 5 hospitals as of
Mm-hmm.
now where we have facilities and like a transplant specialist who can actually
Yes.
do the stem cell. You want to elaborate on that a little bit lang, Doctora?
Yeah, so as I mentioned during our conversation earlier, so we actually have the Philippine Society of Bone Marrow Transplantation, and there are around 17 members. So these are transplant specialists who do the stem cell transplant. So for most of the hematologic malignancies, stem cell transplant is the definitive management for the patients. And then we only have 5 hospitals that are able to do stem cell transplant currently, but hopefully we have more. So the setup is special because of course we have to have the specialists who will be able to do the harvesting of the stem cells, and then also
Mm-mm.
the conditioning regimen or the conditioning chemotherapy given to the patients to prepare them for the transplant, and then eventually the transplant itself. So it entails like a special environment for the patient because
I see.
they have
Okay.
no blood cells of their own, so they have to be really the prevention of acquiring infections is very
Uh-uh.
important.
Yes, yes, yes. So that was a big learning point for me, I think, in our earlier conversation. Di ba? Kahit na 120 kayong hematologists, not everyone can perform a stem cell transplant. You really have to
Yes.
parang specialize pa, no? And
Yes.
train further before you are able to adequately perform the transplant, no?
Mm-hmm.
And then take care of the pre-transplant and then the post-transplant, no?
Mm-hmm.
Doctor, I just want to address some of the questions before we go to mga management na and
Yeah.
then the financing questions. There are a few sort of like parang diagnostic
Mm-hmm.
questions here. Where is your clinic and time? Doctor will type that out. Are patients with diabetes vulnerable to hematologic malignancies?
There are actually no studies relating diabetes
To
to
diabetes.
hematologic malignancy. So most of these hematologic malignancies still come from sporadic mutations.
Okay, understood.
Mhm.
So you're saying you can't rule that out specifically, except that we just don't have data right now, no? Parang
Yeah,
how
but
diabetes is correlated to
yeah, how
developmental health. Yeah,
diabetes is correlated to hematologic malignancies. Although we don't really see an association.
I see. Okay, thank you. Very clear. Is nutrition a factor in hematologic malignancies? I guess you can answer
Um,
this in terms of development and then also maybe for another response to treatment.
Development-wise, not really, although some nutritional deficiencies might cause hematologic abnormalities such as like iron deficiency anemia or
Mm-mm.
megaloblastic anemia when you have deficiencies in folic acid or
And
vitamin
folic
B.
acid.
So not really for the development, but nutrition is of course very important for hematologic malignancy patients or cancer patients undergoing chemotherapy. So um we have to optimize them in terms of nutrition for them to be able to respond well and tolerate the chemotherapy well.
Chemotherapy. Yeah. Okay. Okay. So particularly important as a determinant, no,
Mhm.
for
So actually,
successful treatment.
in NKTI, like we have a nutrition. There is a nutrition specialist on board for patients
Okay.
undergoing the transplant.
Thank you, Doctor. Why do patients experience night sweats? As sinus ito, we talked about that earlier,
Mhm.
na, di ba? Maybe let's address this na rin. Are there preventive measures for hematologic malignancies? You already were tackling about the mutations, di ba, that will
Mhm.
lead to the, oo.
Mhm.
So, yung mutation, wala kang magagawa dun. But are there any preventive measures for hematologic malignancies?
So preventive measures, most of the other um, like risk factors that we've identified for hematologic malignancies would be like exposure to radiation and then exposure to previous chemotherapy. So unfortunately, these are of course when the patient is exposed to these, most likely they are being treated for another kind of cancer. So
Yeah.
unfortunately, there's really nothing we can do about it.
Okay, okay. Quite
Mhm.
unfortunate, no? Pero
Yeah.
again, in summary, walang preventive.
Yeah.
Doctora, could you consider a recurrent low WBC as a sign of hematologic malignancy? You tackled this a little bit, but if you can elaborate on it.
So most of the hematologic malignancies would actually present with high WBC, although we do get some acute leukemias that might present with low WBC. Although for low WBC, mas ang una namin iniisip would be like autoimmune conditions. So it's
Mhm.
still not, it can still be a presentation for um, hematologic malignancy, since all of the blood cells are being made in the bone marrow. So if there is like
Mm-mm.
increased production of these blood cells, of these blast cells, cancer cells, then of course your white blood cell, your red blood cells, and your platelets, the production might be compromised. So it can be a sign of hematologic malignancy.
Okay. Yes. Thanks, Doctor.
Mhm.
I think those are the medyo mga diagnosis questions.
Mm.
I'll shift a little bit to maybe treatment, no, and general management. So you showed a slide of parang yung the general management approach for hematologic malignancies. Quite a long list. And of course, it's important kasi
Mhm.
these are malignancies. I guess just speaking on behalf of all of the primary care doctors in the room, those
Mhm.
of us who are GPs, family doctors, other primary care healthcare professionals. So what is there a role for us in primary care when you're faced now with like a diagnosed case of hematologic malignancy? Say, something siguro na yung medyo indolent ng konti, mga CML, CLL,
Mhm.
diba? So what can we do to maybe, assist you in your role in the parang definitive management?
So for example, um, the treatment really is very specialized. So ideally, yun nga, it should be a hematologist managing these patients. But for example, the primary care physicians, when you get a patient who has a suspected hematologic malignancies, most of them might have anemias or thrombocytopenias, low hemoglobin, low platelet. So you can already start by giving the patient like supportive transfusions, and then the primary care physicians can also be the ones referring patients to the access sites for the for CSP map and CAF. So like for example, the more indolent cancers like in CML, where in the treatment is just tyrosine kinase inhibitors, an oral medication, so you can refer the patient to the CAF or CSP
Uh-uh.
map sites, and then the patient will be given the medication, and then you can just help us like with the monitoring of the patient, CBC wise. Mhm. So if the
Yeah,
patient is already having a hematologic response, meaning the blood counts are relatively normal, then the patient can be managed with the primary care, lalo na
yeah.
kung medyo malayo siya from the hematologists.
Yeah. Okay. So there are naman, no, like really specific responsibilities, and there is a role. So just to summarize, let's repeat that, Dr. So
Mhm.
obviously, our role in the early diagnosis, diba? Like really
Yes.
catching it early and making sure that they're referred to you. Uh, and then the referral, no, and I want to tackle that a little bit later, no, how to refer dun sa mga funds in the
Mhm.
specific centers.
Yes.
And then pag kunyari may treatment na from a rheumatologist, right? And the patient is undergoing treatment, it's
Mhm.
really helping in the monitoring of the treatment and
Yes.
providing the supportive
Mhm.
care, no? Did we summarize that correctly?
Yes, Doc Awi.
Great. Doctor, there are a few management questions. Let's tackle ng mabilis para we can go to the financing.
Mhm.
Okay. A little bit of a technical question. I don't know if you can answer na super mabilis. The very first one, and I want to ask this kasi siya yung una. What are your thoughts on taking rituximab and eltrombopag for chronic ITP? And how long can patients take prednisone? Is chronic ITP ba a hematologic malignancy? Hindi, di ba?
Okay, sa ITP or idiopathic thrombocytopenia is actually not a
Not
hematologic
a malignancy.
malignancy. Yeah, it can be a primary problem, which is idiopathic lang, or it can be secondary from like other diseases. But prednisone is still the first line, or
Prednisone.
steroids is still the first line treatment for
Oo.
ITP. Rituximab and eltrombopag are down the line. So if the
Right.
patient is responsive to steroids, then we can give them the lowest dose of the steroid possible. So for ITP kasi, we don't really try to achieve normal platelet counts anymore, for as long as the platelet count is more than 30 and the patient
Oo.
does not have any bleeding, then pwedeng walang treatment or very low dose prednisone. Like sometimes I give my patient 5 milligrams MWF, or if you can put them off the steroids, okay lang. But if
Uh-uh.
they're not responding to steroids, then that's when we start considering giving them etrombopag and rituximab.
Okay, thank you. Recurrence of hematologic malignancies. Kunyari, I guess especially the indolent ones, pag medyo
Mhm.
magaling, those can recur, di ba?
Yeah, so
Yeah.
hematologic malignancies can still relapse.
Uh-uh.
There are also guidelines for how to manage relapse and refractory diseases, but medications and management for those are still available naman po.
Okay, okay. And then this one before we go to are stem cell transplants shouldered by any of these funds by the CSP map, for instance? Is that sagot ng kunyari the patient qualifies for CSP map or CAF? The
So not
transplantation ba is
entirely.
not
Yeah, not
entirely.
entirely, because as I mentioned, the CAF has a cap of 150,000, and actually transplant can be as much as like 1 million for autologous and 2 to 3 million for allogeneic. So not entirely. I don't have the figures for how much CSP map is able to cover, but it's really mostly medications kasi yeah, for CSP map. But
Mm-mm.
I have a patient with lymphoma who was able to undergo autologous stem cell transplant. They were able to like pool various guarantee letters from different organizations, PCSO, DSWD, and LGUs, and then they had to like I think cash out around 200,000. So still
Mm-mm. Mm-mm.
relatively
Malaki pa rin, no, yung
yeah,
na-cover.
malaki
Okay,
naman yung
okay. That's
na-cover of
good.
these various finance assistance, yeah,
So,
available for
Doctor,
this
on that
patient.
note specifically, no, and to our audience, I'm sorry, this will be our last question, no, but again, the most important point, I guess, is so you because you said in your summary, let us assist our patients in
Mhm.
overcoming healthcare system barriers, and of course, biggest barrier, the financing of their treatment, diba?
Yes.
So you said particularly like us as primary care
Mhm.
doctors and other practitioners can help with the navigating into the funds. So how do you do that specifically? And you elaborate it a little bit. Summary bullet points. How do you do that? You just refer, if kung meron sa hospital,
Mhm.
pwede mo na refer dun sa program, is it?
No, I ideally, well, it really should still be from a hematologist
From a
because
hematologist.
under the IRR of these assistance funds, it has to be the medical certificate or an abstract and the protocol and prescription from a hematologist
From
or
a
an
hematologist.
oncologist.
Oo.
So it has to be the hema or the onco who will provide these papers for the patients, which is part of the availment of these funds. But
Okay.
yun nga, the very important for the primary care physicians is catching the disease, also have a high index suspicion for it, and then refer it to your hematologist so that we may be able to help the patient in the further workup for these. Like ano yung mga susunod na kailangan gawin, and then once you establish the diagnosis, ano na yung mga treatment for it.
Okay, okay. Thank you so much, Doctora, for answering all those questions, all the rapid fire questions, and I'm sure that everyone in the room is also thanking you for helping us learn about hematologic malignancies. And then I love the way you ended it. Now, cancer nga is not anymore a death sentence, but there are so many management approaches to cancers, and in particular hematologic malignancies. I think we really just need to help our patients access the care
Mhm.
no, that is available to them, access all of these programs, madami naman po, no? Just to note also the patient access programs and the pharma companies are available also. And I guess we just need to partner with our hematologists, your friendly neighborhood hematologists, para po we work together to help our patients access these programs, no? So, Doctora, thank you so much. On behalf, we are very grateful for your time and expertise on behalf of all of the organizations behind this webinar series and the webinar team. I'm delighted to present you this certificate of appreciation. Doctora, thank you so much.
Thank you so much, Doc Awi, and thank you
Thank
to
you po.
everyone.
Class 1998 would like to thank those who helped make this webinar possible: the University of the Philippines, Manila, the UP Medical Alumni Society, the Postgraduate Institute of Medicine, the UP Information Management Service, and our sponsor for this webinar, Takeda. Maraming salamat po. Two important reminders. The first is I'd like to invite all of you to our next webinar, and that's happening on Monday, November 6th, 12 to 1 p.m. That webinar will be about the management of ventricular arrhythmias. Our expert speaker will be Dr. Michael Joseph Agbayani, Clinical Associate Professor at the UP College of Medicine, and he is the head of the Central ECG Station of the Philippine General Hospital. You can use the same Zoom link to register in advance or use the QR code that is shown here on this slide. And then finally, to receive your certificate of attendance, kindly answer the evaluation form, which you can access through the second QR code. We will also post the URL in the chat box now. Please note po that you will be able to receive your certificate only after answering the evaluation form. So please ensure that the name you enter in the form is the name that you want to appear in your certificate. Once again, thank you so much for participating today. Thank you to Dr. Quero. We hope that you learned that what you learned today will be very useful in your daily practice. See you next time as we continue to unlock knowledge for primary care doctors and allied medical professionals. Have a great rest of the day and happy weekend po.
Thank you, everyone. Thanks, Doc Awi.
Thank you. Okay, I will dial up now. Dr. Kara, thank you po so much. Appreciate it. Cha and JM and the team, thank you so much. Have a great weekend, everybody. Thank you.